Hello, I'm Gregory Grabowski. I am a professor emeritus at the University of Cincinnati College of Medicine in the departments of pediatrics, molecular genetics, biochemistry, and microbiology, also in the Division of Human Genetics at Cincinnati Children's Hospital Research Foundation. I am here to present some of the findings from the WORLDSymposium that will, I think, change the way we think about Gaucher disease in several ways and the way we treat patients. And I think this is important. And as many of you know, Gaucher disease was thought to be just a disease of macrophages. And they are derived from monocytes, which come from bone marrow, and they get distributed to various tissues in the body. Of course, now we know that this is a much more complex system. And that is part of what we're going to talk about today. Certainly the Gaucher cells shown here in the bone marrow with this wrinkled tissue paper appearance is classic. And this, of course, is from Gaucher's original thesis on Gaucher disease in 1882. The enzyme defect in Gaucher disease is glucocerebroside, or it could be called acid or lysosomal beta-glucosidase, to be distinguished from the non-lysosomal beta-glucosidase. And GCase is also used commonly in the literature. GBA1 in italics is the gene encoding this enzyme. And it's synthesized, the enzyme is synthesized in the endoplasmic reticulum and transported to the lysosome by a system that's different than the mannose-6-phosphate system used by most other lysosomal enzymes. In the lysosome, it functions to cleave two specific substrates, glucoceramide, or GB1, and this is a glucose, this is a ceramide, or lyso-GB1, or glucosphingosine, this is glucose, and this is a sphingosine, you're missing a fatty acid acyl chain. These are very important substrates, and these are highly, particularly lyso-GB1 toxic compounds. So the question becomes, how do the normal mutated enzymes differ, and why is that important? And also, what is the relationship between the mutant glucosidases and Gaucher disease phenotype? Classically, the phenotypes are divided into three subtypes or types. Type 1, 2, and 3, distinguished by type 1 not having early onset progressive neurologic disease, whereas type 2 and 3 have that in varying degrees. For example, you can subgroup these by age of onset and diagnosis and rapidity of progression for all of them. The unique one is type 3C, which has cardiac calcification and aortic involvement and is unique. The residual activity in vivo is reflected in these subtypes as we move across. The less amount of enzyme activity in vivo being associated with more severe disease. And this is shown here very clearly. N370S is an allele that's associated with non-neuropathic or Gaucher disease type 1. And as you can see, if you're homozygous for that mutation, your age of onset is roughly 30 years of age at diagnosis. Whereas if you have an L44P mutation, which is one common in the neuropathic forms of the disease, coupled with the N370S, the age of onset drops dramatically down to about 15 years. So the amount of enzyme that these people have is much less. And if you have an 84GG with an N370S, the age of onset is about 5 years because this is a null allele that produces no enzyme whatsoever. So there's a correlation then between in vivo residual activity, not test tube activity, but in vivo residual activity and severity of the phenotype. An overview of the Gaucher topics now at the meeting was that in general, there were new developments in treatment approaches, enzyme replacement therapies of different kinds, gene therapy with or without a combination of variant enzymes that have been modified to be either more active or more stable. There are also allosteric chaperones and the activators that move the enzyme to the lysosome or activate it within the lysosome. There are new assessments of the treatment outcomes, and there are new studies on pathobiology and the development of new human-based models, as well as some insights into GBA1 related Parkinson disease. So let's move to the clinical studies and assessments. This study by Becker-Cohen was a safety and efficacy trial of rapid enzyme therapy infusions using velaglucerase. And it was stratified so that you started at 60 minutes infusion, and over a period of 6 biweekly infusions, that was reduced to 10 minutes. And then that was all done in the hospital, and then you do home infusions. The small study of 15 patients, they all received a high dose, undefined in this abstract, of velaglucerase. And after 18 months, it was shown to be safe and effective as slower infusions. So this is potentially a way to lower the burden of time spent being treated for this disease by these infusions and having to go to a hospital. Also, there's a paucity of data in younger children with velaglucerase, although with imaglucerase, there's a fair amount of data on this in type 1 and type 3 Gaucher disease. But Gaucher is starting a study in children under the age of 4 or at 4 years of age for safety and efficacy. And it's going to have a retrospective component of 36 months and a prospective component of up to 18 months. And all the standard parameters of organ involvement and biomarkers will be measured. And this study is enrolling, and they should keep that in mind if you have patients in that age group. Another question is always in the literature is, what about the switching from enzyme replacement therapy to oligostat or substrate reduction therapy? It's actually substrate synthesis inhibition therapy, because enzyme therapy is also substrate reduction. This was done in Gaucher 1 patients in Israel. There were 43 patients involved. They switched from various doses of enzyme therapy to oligostat and were stratified by the P450 enzyme CYP2D6, since that is the metabolizing enzyme for oligostat. And you monitor this to make sure you get the dosing right, because the various ways in which CYP2D6 modifies oligostat. So what was the reason for trying to do the switch? Well, oral dosing was thought to be more convenient, certainly kept people out of the hospital for coming to the hospital, and potentially is useful. Maybe they were having suboptimal responses to enzyme therapy, or they're having adverse reactions to enzyme therapy. All patients but 11 continued in the study, and of those 11 patients, 10 who stopped and left the study were from a single center, suggesting an interesting aspect of the study of what the one center's influence on patients could be. There are no drug-related serious adverse events, and other than a couple of mild transient gastrointestinal symptoms, no other things were found. And the patients remained stable, indicating that, like the other clinical trials that were done in a real-life situation, enzyme replacement therapy and oligostat therapy seem to be very similar, and oligostat can keep you stable and is useful. Another way of looking at data from clinical trials is to capture real-life data and from emotional well-being, goal attainment, and Gaucher-specific measures. And there's a smartphone application being developed right now. A study will be done with 20 patients being recruited. You have to have an iPhone to do this, by the way. Look at patient input into clinical decision-making. Who's going to assess what kind of therapy you're going to have, and whether you switch from intravenous enzyme therapy to substrate reduction therapy with oligostat or some other compound. So this is evaluating the transition from ERT to SRT and then back to ERT for velaglucerase. What were the reasons for doing that? And this is going to assess the impact of patient and professional interaction and develop a digital tool to capture some of the components that are more important to Gaucher disease patients in their therapeutic regimen. Very important study. Now, a lot of papers were on biomarkers with a particular focus on lyso-Gb1 or glucosphingosine. I urge you all to download this paper. It's free, by Califf in 2018 on the definition of biomarkers. And biomarker definition and validation is a very, very important aspect and does relate to a couple of abstracts. One question was, is lyso-Gb1 a reliable biomarker for treatment effect? And the focus, of course, is in GD1, 2, and 3. The study is called LysoProve. It's a longitudinal observational study of a fair number of patients with GD1, 2, and 3, and 28 patients that had unreported genotypes. So in plasma, lyso-Gb1 in Gaucher disease 1 was 244, where the mean was 386 in Gaucher 2 and 3. Not much of a difference there. And enzyme therapy was started in 21 Gaucher disease 1 patients, and the expected spleen and liver decreases and increase in hemoglobin were seen, and there was a 45% decrease in lyso-Gb1 after 12 months, indicating that this is a reasonable marker for disease activity at some level. Now, this is a relatively small study in a sense, and it is very important that all of these measurements were done in one laboratory. In a different study, the question was raised whether or not lyso-Gb1 was a reliable diagnostic tool for severity. And it's a 7-year experience in 444 patients suspected of having Gaucher disease, of which 22% ended up having Gaucher disease. And 59 of 99 patients with GD1, there was an age-related diagnosis to the severity of the type of Gaucher disease type 1 they had. In other words, how severe was their whole disease involvement? A small sample of children with Gaucher disease that was neuropathic. Now, the interesting part of this study was that in lyso-Gb1 was stratified with the severity of Gaucher disease type 1. In the what were termed to be mild patients, the value was 194, a mean. And in the more severe cases, the value was 447 nanograms per mil, with a wide variation here. And in Gaucher disease 2 and 3, it was 325. That's not a whole lot different than these other numbers, and the spread was very wide. So we have to really see the data to see how well this correlates with the severity of the disease. In non-Gaucher disease patients, in other words, normal people, the value is about 5. In the carrier, the authors said that it was 5.8, and they said this was different. And we'd have to see the data to see if that is a valid conclusion too. But you do need confirmation, not only by gene sequencing, the whole gene sequencing, but also enzyme activity to diagnose Gaucher disease. Now, of interest has been GBA1 related Parkinson disease, and more basic studies are needed here to understand the mechanism of how this happens. It is clearly different than what is happening in the Gaucher disease brain. Most GBA1 related activities have to do with carriers of GBA1 mutations and the development of Parkinson disease. An interesting study done by Frutos was on the evaluation of serum lipids that we usually don't look at in Gaucher disease in an Iberic population. And a fairly large study with a total of 278 patients with either idiopathic Parkinson disease, Gaucher disease, 15 Gaucher disease GBA1 carriers with Parkinson disease, and 94 controls. They used various studies to score and rank the kind of disorders that they have and whether or not they were related to these lipids. There are increases in phosphatidylcholine and a decrease in lysophosphatidylcholine. And lysophosphatidylcholine is just like lyso-Gb1, where it's missing one fatty acid acyl chain. And they were in Parkinson's disease, Gaucher disease, and in GBA1 related PD. There are increases in lysophosphatidylcholine and plasmalogen phosphatidylcholine in Gaucher disease and Parkinson's disease compared to controls. And there was an increase in lysophosphatidylserine and phosphatidylglycerol in Gaucher disease. So it wasn't occurring in Parkinson's disease. And this builds on a previous work that was done in 2015, which showed very specific generalized complex lipid abnormalities occur in the membranes of lysosomal storage diseases. And they're different in each one, and specifically in Gaucher disease, it differed and was able to predict the kind of immunologic response that the patient had. And these are not just the glycolipids that we talked about that are substrates. So there's a disorder of a lot of lipids in this disease. An interesting small study of non-motor symptoms in patients with Gaucher disease, and they looked at hyposmia, REM sleep behavior disorder, constipation, cognitive impairment, and depression. And these were done over a 3-year period from 2018 to 2021. A small study of 15 patients. 8 of those patients had presented with one non-motor symptom, but they were the same and hadn't changed in 3 years. And it did not correlate with the severity of the L4P variant. And importantly, the number of non-motor symptoms may be related to predicting Parkinson's disease, because one patient with several of these non-motor symptoms went on to develop Parkinson's disease. Now, we need some better models for studying Gaucher disease and Parkinson's disease outside of the animals, because they have not proved to be of direct relationship to the humans. So here's a technique, and they're both based upon the use of induced pluripotent stem cells. And this is called CRISPR-I, or CRISPR interference. And what this is a genome-wide technique to decrease transcription of many genes. And then you can clone these out after a genome-wide targeting and dilute them out per cell, then to a single gene abnormality in the cell, and then evaluate their effects modulating GCase activity in wild-type N370S homozygotes and in Parkinson's disease. So this is an interesting and important approach, and I am assuming that a fair amount of data are going to be coming out over the next few years that will be very important and relevant to humans. Similarly, it's one thing to study single cells in cultures or to study animals, but it's another thing to study what are now becoming what are called organoids. And here, Yin developed some organoid models, which are made up of multiple different cell types that are present in the brain and are interacting with each other in disease states. And they developed these from iPSC cells. And they're looking at the human organoid using a midbrain model. And they found that a culture of the Gaucher disease midbrain organoid had reduced efficiency compared to isogenic cells. Isogenic cells are, let's say, N370S cells where you've used CRISPR to change them back to normal. And so they have all the same genetics, except the mutation is now gone. And they were reduced efficiency in abnormal neuroectoderm, immature dopaminergic neurons, disrupted neuroepithelium by week 3, and attenuated neuronal differentiation. This is a potentially improved platform for mechanistic and therapeutic evaluations to understand what's going on in Gaucher disease and in Parkinson's disease, or Gaucher-related, GBA1 related Parkinson's disease. So in conclusion, I think you can get the feeling that the Gaucher disease research is really thriving, and the input from the neurologists with Parkinson's disease and their interests make this growing and thriving even greater. The clinical trials assessing therapies for new subpopulations and drug switching. How do we pick those people to treat with what drug, and how do we do that, and when do we switch drugs? There are better methods to monitor therapy and disease progression. Maybe some of the biomarkers like lyso-GB1 will be very useful. But we have to understand the link between Parkinson's disease and Gaucher disease, as GBA1 mutations are the most common factor for increasing the risk of developing Parkinson's disease in a lifetime as a heterozygote. And we know a whole lot more now than we did before, but we certainly have a long way to go. Thank you.